Let's hear now from Dr. Brad Greenberg from Salem Regional Medical Center. Joining us now for an update on his work at Salem Regional Medical Center, Dr. Brad Greenberg is on the phone with us this morning. Dr. Greenberg, good morning.
Good morning.
Always great to speak with you, and we wanted to ask you, well, we always have these burning questions every week to ask you and the other medical colleagues at Salem Regional Medical Center about the latest news that we're hearing about with COVID-19. So let me ask Megan to get us started, because I know you have a lot of questions.
I do, as always. So let's talk about Fomite Spread, or spread on surfaces, because there seems to be some new info about that. And
Fomite, different from Vegemite, which is Australian.
Yep.
And a different kind of spread.
Yep.
Please continue.
Okay. Thank you for breaking that down for us, my lovely co-host.
I'm here to help.
And if we do find this virus is on surface for a long time, do they remain infectious?
So, Megan, that's a great question. There has been a lot of development in our understanding of fomite spread. So fomite spread, essentially, we usually talk about aerosol spread or droplet spread, and that's where you would inhale the particles. Fomite spread is where it's like sitting on a surface, you touch it with your hand, and then you might take that particle, which is on your fingertips, and then you may transplant that, or auto-inoculate yourself, put it in your mouth, in your nose, or rub your eye. So you can't get the illness through your skin, but you could perhaps carry it on your skin and then stick it on a mucous membrane. So the component of fomite spread really is still somewhat up in the air. So we like to try to understand how long do these things last on surfaces. And it is a good point that you bring up, is sometimes those things can be detectable. Like you could find with a laboratory test, there's bits and pieces of COVID-19 on a surface. But really what we care about is how long are viable, transmissible, or infectious viral particles actually present on those surfaces that you could actually get sick from. There are illnesses like respiratory syncytial virus, or RSV, that are known to be pretty hardy on surfaces like that. And there have been some conflicting studies. Early in the pandemic, there was a cruise ship where you'd find these things on the surfaces for 14 days, but we weren't really sure if those were infectious. And more recently, there's been some discussion about both, I think it was paper bills, like money, and also smooth surfaces where the virus seemed to persist. And there was a question about whether or not it was transmissible. So it's still somewhat of an open question. With the recent information, we actually revisited some of our policies to determine whether or not we needed to make any changes. And really the most important things were about hand washing frequency and about making sure that you're occasionally disinfecting high-touch surfaces. So we didn't make any modifications to our policies at the hospital because we were already paying so much attention to frequent hand washing and frequent disinfection. So good question, but common sense practices are the response to it.
Great. And I also have a question about antibodies, because that has been in the news for quite some time, actually, testing blood for antibodies. And how long do antibodies remain in our systems? And is there a difference between whether the person infected was asymptomatic or symptomatic?
So two very good questions. So, and the answer to both, of course, is it depends. But I think that antibodies remaining in the system, it really can vary. Most coronavirus, or not, you say not COVID-19, but other forms of coronavirus are the common cold. And it's pretty well known that coronavirus really can provoke an antibody response, but that antibody response only persists for, say, 3 to 6 months. But other illnesses sometimes confer lifelong immunity. And those kinds of things also we like to seek out when developing vaccinations, for example, where you'd like to have a single vaccination that would confer lifelong immunity, where you'd have antibodies that would persist. So every disease is a little bit different, and we continue to try to develop an understanding of what happens with antibodies and how long they last. Now, there has been some discussion about, does the severity of your illness that you would get with COVID-19 impact your basically the production of antibody? And it seems, again, there's a lot of study that's continuing with this, but it seems like it may be the case that if you have severe illness, you may have antibodies for a longer period of time. Now, we continue to develop an understanding as to what the antibody presence means. We'd like to consider that that does mean that it confers immunity. However, there have been a series of cases that continue to be described that are about reinfection, which concerns all of us, is that perhaps having the illness once does not necessarily mean that you couldn't get it again. And each of these cases is notable because we try to study them and understand the why, and also try to continue to understand the immunologic responses that individuals or populations have to when they contract COVID. So a complicated answer to a question that I really wish we did have a definitive answer that we could reassure folks with. But really, in this particular case, I still believe that, this is an ounce of prevention is worth a pound of cure. And so do everything you can to not get the illness, and we'll continue to do the science to fill in the gaps about what happens and the immunologic consequences of it.
And Dr. Greenberg, I guess we're still learning more every day, aren't we, about these types of things? So that just goes without saying. I wanted to ask you a bit about the use of steroids in treatments that we've been hearing about. And I know that steroids are used for a number of treatments and things like that. Could you give us a bit of a maybe lesson on what steroids are and how they're being used, especially with COVID? But I imagine there's different types of steroids that can be used in different ways.
Absolutely. And so these steroids, they're not the kind of steroids, they're not anabolic steroids like the kind that that people would use to increase muscle mass and whatnot. These are glucocorticoids. These are what we're using essentially as a ways of modulating the immune response or the inflammatory cascade. And so there has been some consideration that perhaps blunting the overwhelming systemic inflammation that goes along with fighting infections maybe you might be able to if you could blunt that immunologic cascade, that you could have better outcomes in patients. And that's the whole goal with giving someone steroids, is that you're trying to reduce the overwhelming immune response or the cytokine storm, so to speak. And you're trying to prevent the consequences, with respiratory failure or low blood pressure, et cetera, that you would get with this unbridled inflammatory response. So timing has been a real issue, when you give the steroid and to whom, and when in the course of their illness. All those things are really under study. Initially, we thought that from a study in the UK that administering dexamethasone to these folks would reduce mortality. Now it looks like there are subsets of patients, and the timing of which becomes important to make sure that we give the steroid at the right time to the right subpopulation to reduce overall mortality. Steroids are a very frequently studied class of medications. Everything from spinal cord injuries to systemic infections, or what we call sepsis, has had studies devoted to it that are related to steroid use. So it makes a lot of sense that we would try to extend their use to COVID-19. And so we're going to continue doing those and continue to try to match up the right patient with the right kinds of intervention, and then make sure that we stay abreast of all of the new research and development for this subclass of medication.
Understood. And still not kind of a one-size-fits-all then treatment for these COVID patients that you're seeing.
Absolutely. I mean, it really does seem that this particular illness is somewhat protean. There's a lot of different impacts to these folks, both in the acute illness syndrome, folks having no symptoms, minor symptoms, some symptoms that are sort of curious, like loss of taste and smell, and then those folks that have severe acute illness, and then those folks that have the COVID long haulers, or the long COVID folks that have weakness and neurologic findings, et cetera, myocarditis, a whole range of different kinds of things that we're beginning to understand. And so it does make sense that the treatments are tailored to the individual experiences, and we do our best to use all of those things that exist in our armamentarium to match up the right patients with the right therapies.
Very good. And speaking of treatment, there have been some studies suggesting that the mortality rate among hospitalized patients has decreased. Is this because treatment is being more refined, or is the virus possibly mutating before our eyes?
Oh, I think that's a great question, Megan. We're actually, I think it may be something more simple than that. which is that this is a novel illness. When this showed up and overwhelmed many facilities, and we didn't have a lot of experience with it, I think that it makes sense that we are getting better at taking care of the very sick over time. And as we refine our understanding and add different kinds of medications and different kinds of approaches to ventilated patients and whatnot, deciding who needs to be on ventilators, what kind of respiratory support they need, we're doing our best to reduce overall mortality and morbidity across the board. So it's reassuring that as over time, even though we're still seeing large numbers of pretty sick folks, that we're getting better at taking care of these folks, and we're able to deploy a new and more advanced set of tools over time also. So I find it hard to, I know there has been some variation as far as like when they do genetic or genotype sampling from some of the viruses, but I don't necessarily see substantial differences in the virus itself as it impacts our population. I think more it's our responses to it and how we're able to better support populations through the illness.
Yeah, some rapid speed learning going on. And then our last question today is a convalescent plasma update.
Well, so convalescent plasma essentially involves, we've talked about this a little bit before, but it involves taking folks that have had COVID-19, and then they are kind enough to donate plasma, which includes lots of antibodies in that plasma. And then that is refined and then basically is transfused into populations that may benefit from that. Folks that are sick that may need an additional infusion of what we call passive immunity. Passive immunity, where you're basically delivering antibodies that are already made into another person. And so there has been some conflicting data about the utility, although presently convalescent plasma does have an emergency use authorization, I believe, from the FDA. But we're not using it as much at San Juan Regional Medical Center. We definitely do our best to make these things available. We find it very important to match up the right patients with the right kinds of therapies. Interestingly enough, the principles behind convalescent plasma, that is to say, infusing antibodies that came from somewhere else and into a patient, is the same principle that is behind the monoclonal antibody therapy that President Trump received, the Regeneron therapy, which is the infusion of antibodies that are not necessarily from another person, but they're engineered in a laboratory. And that is the same principle. So the convalescent plasma and that therapy are both still under study. And so it's definitely not, say, a slam dunk therapy that would vastly improve this. So this is just part of the scientific process where we're trying to create access, sometimes through compassionate use, sometimes through emergency use authorizations. Those are two different FDA labels for how patients can receive medication sort of before they go through the whole FDA process. But we're trying to improve access and we're trying to improve outcomes. And so using different passive immunity strategies is part of the whole puzzle. And we'll use science and figure out how to move forward and get the best possible constellation of therapies available for patients in the Four Corners.
Very good, Dr. Greenberg. And I had one extra question, if you don't mind, and that would be just an update on vaccines. We are hearing that maybe some are in some of these maybe challenge phases of the vaccine, and maybe from the materials that you read and what you hear from your colleagues, kind of where do things stand? I think we're still several weeks or months out, aren't we, from a practical vaccine to be used in a big population?
I think that's correct. I think that the vaccines continue to be in development. I know three major manufacturers are in phase 3 trials, so large-scale phase 3 trials. But it does look like, as we would expect, as they give the vaccines to, say, 40,000, 50,000, or 60,000 folks, that in those subpopulations you're going to have events that cause those trials to stop and be examined. That is a normal thing. That tells me that the FDA process for safety is working just as designed. And so, but I do think that it's going to be some time before we see widespread distribution of vaccine. The federal government did request each of the states to submit a vaccination plan, and the states and the state of New Mexico has also requested from us how we might be able to assist with the vaccination process and how we would do it. And so all of those things are in motion. So even though we may not necessarily have a vaccine in hand, so to speak, we're developing plans to rapidly distribute it to the population and to make sure that we work with our partners at the Department of Health to build a system that will be, at least in terms of a framework and an implementation plan, we'll be ready to try and distribute this to the population. So there's lots of work at every stage. The development is part of it, but then the distribution is also a Herculean task. And so we want to make sure that once we have it, we can actually distribute it. And but I actually find I believe that the emphasis on safety and the emphasis on efficacy is really what we need right now. We need to believe that this vaccine is going to work and it's going to be safe. And the fact that they're taking their time and doing this the right way is reassuring. And I think that when we finally have that tool, which will be invaluable, we'll be in a place to make sure that it's available for those folks in the Four Corners.
Very good. Well, as always, Dr. Greenberg, it's a joy to have you on. Thanks so much for taking time out to speak with us today.